morning. We are on time to start, 9:42. While you take your seats, I must admit that I cannot see inside the room because of the light that is hitting us directly here in the eyes. Can you hear me well? Okay. So, my name is Mila Paspalanova. I'm the Anti-Racial Discrimination Advisor for Europe with the Office of the High Commissioner for Human Rights. They asked me to introduce myself because we don't have a moderator for the moderation of our panel. I have the pleasure to moderate an amazing panel of names, big names of researchers and contributors that are going to speak to us about vulnerabilities and data, and start unraveling these uncomfortable topics that kind of always are forgotten when we speak about the level of implementation of the right to health. So whenever we speak about how far we have advanced and where we have to go further, we often forget to highlight in our policies and also through our data that, in fact, we are speaking about level of implementation of human rights, the right to health in this case, as manifested through people and through people's suffering. And we're speaking about physical health, and we're speaking about mental health, and we're speaking about all other intersecting and underlying factors that determine if we are healthy or not. So before giving the floor to our amazing panelists, and we just miss Professor Dr. Niels Schacks because he's sick, unfortunately. We will have more time for questions and answers. I wanted to go briefly through some of the main components of the right to health, not to forget about those, as specified in general comment number 14 of the Committee on Economic, Social and Cultural Rights. And why I would like to do this is because we are going to continue in this panel, and I think during the day, with a discussion that places us nowadays on what's going on in the digital era and how we have to start redefining the concept of the right to health. And in those occasions, what often may happen is that we forget what are the core components of the right to health that are still not well implemented. And when I'm reading those, I will ask you very much to shift your way of thinking from general population, because often when we say general population, we think about white, male, middle-class population, right? And we forget that we have people of African descent, we have Roma, we have poor people, we have people who live on the street, we have people with disabilities, we have people who are gender transitioning in this moment, we have people representing the sexual and gender diversity, elderly populations, youth, children. So when we add all this together, in fact, they are the majority of the population, and to this, when we add the international recommendations from the treaty bodies, committees that explore and inspect state responsibilities to implement human rights, we realize that the biggest level of concerns, in fact, are related to the right to health and to the right to health and social rights of those collapsed in one vulnerable population groups. So we have to remember that the right to health implies availability for all people. It implies accessibility. Accessibility understood as non-discrimination. Non-discrimination is legally enforceable in most states. Physical accessibility, economic accessibility, informational accessibility, and we're going to speak about this today. Acceptability, medical services should be accepted by those people who are using them or to whom we are bringing them closer. And it implies quality. And then we have special topics of broad application as defined by the committee, which include non-discrimination again and equal treatment. And think about those that they also have to be reflected in data. We heard just in the morning that data is not enough to implement human rights, and I'm very soon finishing, but very often we fall in a vicious circle that when there is no data, we do not have the grounds on which to build and implement public policy, And remember that every time when we speak about public policy, we speak about budgets as well. So we need the data. And we need the data on gender perspective, on women and the right to health, on children and adolescents, elderly people, people with disabilities, indigenous people, people from the minorities, people of African descent. So here I will close. And I will introduce our first speaker, and we decided to change also a little bit the scheme of introduction of panelists. I will mention something very brief about all of them, leave them a question, and they will keep on introducing themselves with something that they would like to highlight, either about their line of work or concerns that they have related to the right to health and vulnerabilities and data. So we will start with Maria Țanu. You are free to decide if you would like to speak from there or take the spot here. And I will only say that she is an associate professor in law at the University of Sheffield, United Kingdom. And her research focuses on European constitutional and human rights law, privacy, data protection, surveillance, data justice, the regulation of new and emerging technologies, and the inequalities of data privacy law. Okay? And how all those components affect vulnerable population groups. Okay? So she's going to speak about how should data collection, sharing, and governance be structured to protect those who are left behind, those populations that we define as vulnerable populations, and to achieve this so desirable intersectional health data justice. So I will leave it here. Please keep on introducing yourself. The floor is yours.
Thank you so much, Mila. Thank you. That was a brilliant introduction, actually. I don't need to add anything else to this, I think. I will just try to put my slides. Yeah, they did appear. That's great. So thank you so much for this kind introduction, and also Professor Paul Quinn and the organizers of the HELT Symposium for inviting me to such an exciting panel. As Mila mentioned, my talk, will focus on the following broad questions. So, how should we imagine and think about data collection, data sharing, data governance more generally, so that this can protect vulnerable populations and achieve intersectional health data justice. And as I am a legal scholar, I will try to address this question from a really legal or regulatory perspective, although I recognize that this is a broad question and there are other ways to think about it besides just the legal perspective. In fact, there is the technology perspective, there is a society perspective, and I think we should bring all and combine all those approaches to answer such a question, rather than focusing only on one. But given my personal expertise, I will stick to kind of thinking of thinking on what role regulatory frameworks have to play in achieving intersectional digital health justice. And hopefully my co-panelists will contribute other perspectives as well. So as my time is kind of limited, I will narrow down even further this question to what I consider the primary regulatory framework relevant to data collection, sharing, and governance in the EU, and that is the GDPR. And it is considered, as we all know, the GDPR is considered the gold standard for data protection laws worldwide. However, I will highlight two main concerns regarding marginalized groups that arise from my research. So the first is that the costs and benefits of data protection law, in particular of the GDPR, and its outcomes are not equally distributed when considering the less privileged. And secondly, I will also argue that regulatory frameworks, such as the GDPR, I'll be talking about the GDPR, but more broadly and more generally regulatory frameworks that ignore vulnerable communities create epistemic injustice, and that epistemic injustice is at the institutional level, at the legal level, legislative level, as they construe and structure social understandings, certain social understandings surrounding such communities in a very certain way. And I will illustrate both of those points by drawing on my research on gendered digital surveillance in the context of femtech. I think this case study, femtech as a case study, is very useful in this context because it is at the intersection of data protection law, the GDPR, and also sexual and reproductive health. So some very brief information about femtech in case you might not be familiar with it. I'm sure most of us are familiar with it. So femtech refers to a multi-billion dollar tech industry which offers products, services, software that provide algorithmically derived insights to help women manage their sexual and reproductive health. It includes different apps, for instance, menstrual apps, fertility apps, and so on. It includes also wearables that are worn in, on, or around women's reproductive organs, such as smart pelvic floor exercisers, and also it includes smart sex tech, such as smart vibrators. There are several reasons that explain femtech's popularity. I distinguish them in kind of two categories. So in what I call the push factors and the pull factors. In terms of push factors, so femtech is situated and it emerged as a tech industry in a broader social and medical context characterized by substantial knowledge gaps regarding women's sexual and reproductive health and dangerously under-resourced and overstretched public health services. This leads to women experiencing gynecological problems, often feeling that they're not being listened to, and as a result facing an uphill battle when seeking diagnosis and treatment for gynecological symptoms and conditions. For instance, endometriosis, which takes on average more than 9 years to diagnose and is a particularly painful condition. And finally, there is a widespread tendency, and it's well documented, there is a tendency to question whether women are trustworthy narrators of their own health and pain, in particular when it's about conditions relating to the functioning of their own reproductive organs. So in addition to these push factors that explain femtech's popularity, the femtech also has a very powerful kind of rhetoric or marketing message, and this is one of empowerment. It markets itself as empowering women to algorithmically self-manage their sexual and reproductive health. And I won't say much more than that because Teresa's work is really phenomenal on this topic. So this is really draws on Teresa's work in the area. In my project, so I had a recent project studying gender surveillance in the context of femtech. We studied the privacy policies. We selected 42 femtech apps. 27 of those were apps only, 15 were apps associated with a wearable as well. And we looked at two types of documents. We looked at privacy policies and we looked at terms of and conditions, or sometimes this document is called terms of service or terms of use. What we found is that overall, femtech privacy policies and terms of and conditions lack compliance with the GDPR. The privacy policies were vague, ambiguous, and they lacked overall certainty. We saw a lot of, we may collect your data, whatever that means. We may be obliged to share your data. We may be obliged to process it in this way. We may share it with third parties, and so on. Secondly, while femtech data are particularly intimate, they concern women's and girls' sexual and reproductive health, we found that certain policies failed altogether to recognize that. Sometimes they failed even to recognize that they are sensitive health data under the GDPR. They contain some generic categories that made no sense in terms of the law. For instance, wellness data, well-being data, whatever that means, and which is also very problematic. And finally, we also found many problems in terms of substantive compliance with different GDPR principles. So they were lacking in general in terms of data protection principles, data minimization, purpose limitation, so on. But also in terms of very important things like legal basis for processing, particular consent, and how, in what instances consent could be used as a valid legal basis for processing in this context. Also data sharing with third parties and targeted ads. Data subject rights, we found that many policies did not mention some of them or ignored all of them, or it was unclear how data subjects could exercise them. And finally, we also found kind of discrepancies between the privacy policies and the terms of service. So it would read in the privacy policy of the same app that it's secure, it ensures data security, and then we read the terms of service of the same app, and they would explicitly say they don't have any liability for data security. The app might be hacked, and that is kind of putting the burden also on the users. So it gives us a picture, a very problematic picture of compliance of this industry, of tech industry, with the law we have in place, the GDPR. However, what I would like to focus on today in my talk is not on femtech's lacking compliance with the GDPR. It's rather looking at the GDPR itself and its approach on dealing with data risks and harms as we saw that they might arise from femtech. So, and as I said, femtech, I think, is a useful case study in this respect, in this context, because it is at the intersection of reproductive and sexual rights with their gender dimensions and data protection. So, what does the GDPR say in this context? Let's move now to the law. So I'm sure you're all aware, if you read the GDPR, there is no mention to anything related there to gender or the less preferable term sex. So the GDPR is gender blind. We don't find there any kind of mention to gender. And in fact, even if we look at Article 9, which identifies special categories of personal data, again, gender or sex is entirely missing from there. We consider that a serious omission in light of Article 21 of the EU Charter of Fundamental Rights, that is primary EU law and prohibition of discrimination, which includes and explicitly mentions sex. But that did not find, for some reason, its way in the GDPR. We find that very problematic, that the GDPR makes no mention whatsoever in any of its substantive articles or any of its recitals to gender or sex even, because it seems to, in our view, we argue that it ignores the significance of data protection rights for the safeguarding of women's sexual and reproductive well-being and autonomy. And what we are trying to say is, and this point is illuminated really by the femtech case study, is that personal data can be gendered, data gaps can also be gendered, data subjects can be gendered, and risk of processing personal data can be gendered, as well as data harms can be gendered. And when I'm saying I'm talking about gender here, I understand it from an intersectional perspective that comprises all other elements of potential multiple forms of vulnerability. In particular, we try to focus more on risks. Why? Because they are very important within the context of the GDPR. As you all know, risk occupies a central role in the GDPR. It is the object, is the outcome of this regulation, is a risk-based regulation. Risk shapes obligations within the GDPR, including technical and organizational measures the controllers are obliged to take. It also calibrates obligations. It triggers obligations. And more importantly, one of those is data protection impact assessments, so DPIAs, when it's considered that a certain type of processing will result in high risk. So, while a risk-based approach is central to the GDPR, the possibility of data protection risks being actually gendered or affecting vulnerable groups more broadly has not been considered so far by this law. I therefore ask, whose data protection risks matter within the GDPR? And as the Femtech example shows, the neglect of an entire category of risks, data risks and potential harms, those are the gender risks and harms, shows a differential distribution of the rights and outcomes of data protection. Femtech predominantly relies on and affects women. Its data sharing practices are gendered. They're capitalizing on reproductive milestones. This has effects on the scaling of the accountability of obligations, the implementation of appropriate technical and organizational measures, including DPIA. So in our study, we were looking if any Femtech of the 42 privacy policies that we read, if there was any DPIA, and we found information only in 2 out of the 42, and again, we could not access any such document. So it seems that they consider it not high-risk processing, so not requiring DPIAs. And then these differential distributional outcomes of the GDPR also arise by the fact that controllers are obliged to assess risk based on self-regulatory initiatives, and this kind of exclusive reliance on controllers is problematic if we consider that following general trends in IT law, but in the IT industry, but also in the context of Femtech, many developers and owners, but also funders of the for-profit Femtech products and services are not of the same gender as the users of such products and services. So overall, coming back to my first point that I'll try to illustrate, the GDPR's distributional outcomes are not equal. Whole groups, such as women, and more broadly other groups, it's just I use this as a case study, the Femtech as a case study, are not given proper protections by the failure to recognize gender data risks and harms. And the second concern I have with the GDPR is that by ignoring gender, it creates epistemic injustice. Am I running? Yeah, okay. I'm running late, sorry. And that is, I'm not going to explain what epistemic injustice means. Miranda Fricker has done work on that and has recognized two types of epistemic injustice, hermeneutical injustice and testimonial. Here I consider that the GDPR, by ignoring gender altogether, it creates an understanding at the institutional level that creates epistemic injustice, in hermeneutical epistemic injustice that is structural. And of course, this can have effects on testimonial injustice, or what women or what speakers can say and explain about their experience. So I will leave it there. So to conclude, going back to my first question, broad question, kind of, to achieve intersectional health justice regulatory frameworks, and I looked in particular at one framework here for the purpose of this talk, those are the GDPR. First of all, those regulatory frameworks and the GDPR that I focused on should be egalitarian. So they should be equally distributed to all societal groups, including the most vulnerable ones. I think that is very important. Secondly, they should include epistemic justice virtues regarding marginalized communities. And that is important both to achieve epistemic justice at a hermeneutical level and epistemic justice that is testimonial. And finally, the third point, I think they should ensure fairness in the way vulnerable populations are made visible, are represented and treated as a result of the production of their digital health data. So I did not talk a lot about this point because I know I don't have much time, and I'm also kind of researching. It goes beyond the GDPR on how vulnerable populations, including women, are made visible and represented in the law. But I will leave it here, and thank you very much.
We would like to keep at least 15-20 minutes at the end for your questions, answers, reflections. So please be taking notes during the presentations about the questions that you would like to raise at the end. And at this moment, I would just like to leave for you and for all of us one question, again, on data. There is especially racially and racial discrimination, racism-related data or inequalities-related data that are not collected in the majority of EU member states, with the argument that this in itself is discriminatory. And at the same time, we see how much data is collected. So I would like to ask us personally, us as women, what we would like to share, and I would raise also the very uncomfortable and not so much spoken topic about aging of women and menopause data that are entirely missing and were entirely overlooked, and again, diagnosis, we might finish being diagnosed with psychiatric conditions rather than recognize that we are undergoing through hormonal changes, giving one example. What we would like to have reflected in data collection systems and for what purposes, and what is actually being collected about us, okay? And with this, we continue with another very concerning topic that Liam Quinn is going to present to us. And he's going to speak to us about how genetic and other sensitive data raises important ethical questions and challenges in the realm of law and the areas of vulnerability of certain individuals or group of individuals. And to lower this down to a case study, we are going to speak about the impacts of the COVID pandemic levels on the levels of loneliness in Denmark. Liam is a doctor in population and disease genetics at the University College of London, and his thesis focused on an epidemic of prion disease among populations of Papua New Guinean Highlanders during the 20th century, using genetic data from affected population. Since then, he has been a postdoctoral researcher in the University of Copenhagen, and he's now employed in the University Hospital of Sjælland. Do I pronounce it correctly? In Denmark, where his focus of work is on the use of genetics, again, questionnaire and register data to understand the impact of COVID pandemic. So add again something more about you or your research, and the floor is yours.
Hi, thank you for the introduction, and the previous talk was really fascinating, really good case study. And yes, I'm a bioinformatician, I'm not a legal scholar, but I hope this case study I'm going to show will really interrelate with our core themes of One Health, so using integrated data in a joined-up way, and also with vulnerability, and for the good and the bad, I hope, will become apparent during the talk. But as a further introduction, to some of the work I've previously done. So the main project I'll talk about with loneliness is using a very large biobank and register data, etc. This study, my previous work focusing on Papua New Guinean Highlanders, was a bespoke data set collected by anthropologists over 20 years. And this epidemic of Kuru disease primarily affected women and young children. And we used genetic data and hypotheses from ethnographers and anthropologists to dispel some myths about the impact and practices of women during the epidemic, specifically practices of marriage and migration. So just as a contrast to the later work, this applied a very more specific, bespoke hypothesis and data collection process. Some of my later work also to highlight, again, this sort of One Health aspect of the talks today. I stepped out of human genetics for a while and was working in this paper with Cape buffalo. And it may not seem apparent how this may be relevant to humans, but again, with this joined-up thinking way, Cape buffalo are a cornerstone species in terms of biodiversity and also in terms of food security. They've been a frequent source of pandemics in Africa. So, for example, Italian colonists, when they took cattle over to Italy, to Africa at the end of the 19th century, they carried with them a rinderpest pathogen, which wipes out 95% of the Cape buffalo in a single generation. It destroyed food security because it also semi-eradicated cattle, and around 20% of the Ethiopian population died in a famine. Since then, there's been multiple zoonotic jumps of tuberculosis from Cape buffalo into cattle and back again cattle into Cape buffalo. So this reservoir effect has real implications for food security and particularly vulnerable people who live on the margins in this sense. So just to give you an idea of people like me in the wide array of work we've done, it's not just necessarily biobanks, registers, and questionnaires. It's also people doing a lot of hard work interdisciplinarily with people from other fields to answer interesting questions in a joined-up way. So I'll give you a bit of a background on the biobank. It's the basis of the study. It's the Danish blood donor study. So the main idea around 15 years ago is that when you have a blood bank, you already have a large amount of infrastructure available, collection facilities, and it was a low-hanging fruit in a Danish context to expand this. And this initially was expanded just to as a research resource to answer questions of donor health. So people are more likely to contribute and participate in blood donation schemes if they feel like their healthcare concerns are taken into account. And so initially studies focused on the impact of health of being a repetitive donor, vulnerable groups, if they could be donor, and how this may change entry criteria for being a blood donor. But like any cohort of individuals, which is now around 180,000 individuals in our cohort, they get sick over time. So this has now been expanded to a general research resource, and we have genetic data on around 150,000 of these blood donors, so around 90% now. So to give a better illustration of how this can be a really valuable data resource, here we have this schematic. So people are spoken to when they come into the blood bank across Denmark at multiple bleeding facilities, and they're taken through a consent process where they're told the extent and scope of our research work. A really good advantage with the blood bank compared to other donation cohorts is that people tend to give repetitively. So we can get multiple biological samples over multiple periods of time, which allows longitudinal studies and retrospective studies with multiple time points. We also give people tablets with questionnaires on that they can answer while they're in the bleeding facility. And also in Denmark, we have this excellent integrated citizen e-box system. So all our donors, we tend to send questionnaires once every 2 years, and we get around 50,000 responses. So Danish blood donors appear to be very conscientious participators in this process. We also link, with their consent, their data to publicly available registers. So this includes hospital diagnosis registers, medication registers, procedure registers, etc. And finally, we can link this further to demographic data, which is collected by Statistics Denmark, so we can get further things like employment, family background, etc. So this allows a wide range of studies. I won't go into them all here, but my area is primarily genetics. And another excellent thing is that people tend to be blood donors for long periods of time, so if we highlight groups of individuals or individual interest, we can recall them for deeper phenotyping or questioning or even intervention if necessary. And this all works within a framework, which I'm probably not the best qualified to elaborate on in depth, but it's constantly has to be elaborated depending on innovations with technology and understanding of biology. Okay, great. So the study I've done is loneliness, and I think it's a really good study because it sort of will highlight these themes of One Health, joined up thinking, multiple intersectional data, and vulnerability. So loneliness as a broad philosophical concept has existed for time immemorial, with thinkers, philosophers, artists really interested in it. In the course of the 20th century, it became increasingly more a unit of biological study in itself. This has led ultimately in the last 20 years or so to even genetic studies being performed to try and understand the linkages that we see in people who report high loneliness with comorbidities, if they're biological, mechanistic, or groupings of people based on this. And this paper on the right, with review article, was a real inspiration, where I think part of the field is going is that, okay, we're getting an understanding of individual potential risk factors and comorbidities with loneliness. But in this paper, they look, okay, but perhaps if you layer over that macro factors, so pandemics, the obvious one I'm going to talk about, war, economic crises that happen on a larger scale, how does that interface with this sort of individual level experience of loneliness based on attributes or circumstances? So I'll give you a quick idea of the study. So loneliness isn't like blood pressure where we can get a physical measurement. It's not a biomarker. So we relied on questionnaire and self-reported responses. And there's an internationally recognized measurement tool called the UCLA Loneliness Index. And this is a set of questions we put in our questionnaires that gauges people's levels of satisfaction with the number of social encounters they have, the number of friends they have, the quality of relationships they have. And it's been used in hundreds of studies, and it allows a quantified scale of loneliness that we can use as a measurable outcome. And then the idea was to look at trends in this, because we had sent these questionnaires out during the pandemic at different points, and see if these grouped trends related to individual levels for subgroups and also this idea of macro levels. And then we could use these trends to link them to, again, register data, questionnaire responses, and finally genetic markers. Great. So each round, we would get around 38,000 responses, and to enter into the study, you had to have responded to all rounds. So we didn't have the issue of missing data and that biasing any statistical inferences. So in the end, we had 8,000 individuals who answered all rounds. And as you can see from this, there was an increase in self-reported loneliness during the pandemic. And when we matched this with the social restriction index, there was a clear relationship, which was intuitive, but still fascinating that you see this when you link it to data that is slightly removed. But in terms of vulnerabilities, what we're interested in, perhaps in this sea of 8,000 people, we're missing vulnerable subgroups. So if you look on the left-hand scale, this is still relatively low measures, but they're very statistically significant due to the high number of participants that we have, and it is nice to see this. So the first port of call, which has been a common theme in loneliness literature, is sex or gender experiences with loneliness. And when we split, this is a good point I want to return to later, is that, okay, so we have a group of blood donors, and within that group of blood donors, we've selected for people who have answered multiple questionnaires. So if we just take a snapshot of our study participants, they're very low levels of unemployment. And this will be a recurring theme, this idea of healthy donor effect and generalizability of findings, which we're trying to deal with. But if we move on to the data and how it looks when we stratify in terms of sex, we see not only this commonly reported elevated levels of loneliness for female, but it is further exacerbated when restriction levels are at their highest during the pandemic. This relates to a lot of other scholarship that these macro-level stressors, they further exacerbate gender-based tensions and responsibilities that women feel disproportionately compared to men. So then we wanted to go further. So we wanted to, in a data-driven way, to see if there are any subgroups hidden within here that are lost in this sort of general mass. So we used a machine learning-based data-driven tool which looked at all of the loneliness responses. And when the data was analysed, the algorithm suggested that splitting into 3 groupings was the most parsimonious measure. And as you can see, we've ascribed them these levels. So half of the data points, more or less, were these low loneliness individuals who were robust throughout. And they really biased that original data, that sort of general trend. But within that, we have these other groups. So we have this other group of high loneliness who have, and again, I would ask you to look at the left-hand scale. If you compare it to the previous, we're talking significantly, here we go. We're talking significantly, so you can imagine they would be up to the ceiling, the high loneliness individuals, if plotted on the same scale. And then interestingly, we have this pandemic loneliness group who appear to have low levels of loneliness prior and after the pandemic, but at the height, they reported significantly elevated levels. Again, this would be off the charts on the previous graph. So the question is now, using the data at our disposal, do these groupings, are they reflected in underlying differences and comorbidities? So I'll show some tables, but there'll be a general trend that you see that this high loneliness group, so that they conform to a widely reported trend of young people, particularly young women, reporting very elevated levels of loneliness in societies across the world. And this pandemic loneliness group sort of as an intermediary sort of phenotype, as we see in this trend. Yes, we see the sex disparity I spoke about earlier with women in the high loneliness group. And then we also see people that live alone is significantly high in the high loneliness group as well. Then we also obtained from medical health registers. We took pre-pandemic psychiatric diagnosis and administration of psychotropic medicine. We wanted to take it before the pandemic because we didn't want to confuse, was the taking of medication causing loneliness or was loneliness leading to the medication. So to avoid that epidemiological knot, we used a baseline measure. So we see this general theme with this demographic register-based data for these groups. But then we wanted to see also, do they have different genetic profiles? There's some advantages and challenges when using genetic data to profile groups of individuals. But one of the key advantages is that, for example, some of these things like psychiatric disorders and stuff, they're prescribed during life. So we have these epidemiological tangles, whereas genetics is prescribed at birth. So that makes causative inference a lot easier for lazy genetic epidemiologists compared to people who have to really tangle with these complex, directed acyclic graphs of causation. And also, because it's prescribed at conception genetics, it allows earlier intervention. So if we have a highlight, a trigger for a high loneliness, for example, based on one of these societal measures, we have to wait for that to arise before we can intervene, whereas genetics can be done a lot earlier, which can be, depending on what you're looking at, it can be very useful. So I'll give you a quick conceptual walkthrough of the tool we used, which is a polygenic score, to create a profile of our loneliness groupings. So somewhere in the world, someone will conduct a study based on genetics. So for this example, we looked at a study with around 500,000 individuals and their levels of neuroticism that were measured. So then, if you dig into the paper, you'll find a results table like this, which has the levels, the scores for each genetic marker from the study. So then, if we think of our blood donors, so we look at, if we take the top individual, we go through the table systematically, we check what markers he has, compare it to the table, and we give him a score. Sorry for the formatting, hasn't transferred well. So for example, the person at the top, after we've counted, based on this external studies reporting, he appears to have a cumulative score of 4.5, which may be an elevated polygenic risk for high elevated neuroticism, and the person below could have a negative risk, which would have the inverse effect. Okay, so then we do this for all 150,000 blood donors, so we get this distribution of scores, and then we want to look at how our loneliness groupings we derived look in terms of this genetic risk factor. So as you can see, there's a very significant clear when we plot these polygenic scores of elevated polygenic risk for neuroticism among individuals with high loneliness and intermediary phenotype for the pandemic loneliness group. So I repeated this for several mental health-related genetic phenotypes. And as you can see here, there's a general trend that we always see that there's significant elevated genetic risk for psychiatric disease and autism and other personality traits that may be of relevance. But the pandemic loneliness group, the one that stood out for me was, for example, this elevated genetic association for religious participation. So you can imagine, for example, during the pandemic, these communal activities were removed. And if you had a genetic predisposition, perhaps for this engagement, when this is removed, it may lead to stresses and expression of dissatisfaction with your social life. So, I don't have it. Okay, so how am I doing for time? How much time's left?
5 minutes.
Oh, great, loads of time. Okay, so some takeaways related to the study. Okay, so I spoke earlier about this. You have these individual levels and these macro level events that can impact individuals and groupings of individuals. So what I take away from this is that yes, we have this group of people who generally express high loneliness, and it's related to well-known risk factors, so including demographic, psychiatric disorders, etc. But then this pandemic loneliness group of individuals appear to be a set of individuals in normal circumstances that are just lying on the threshold. They have some elevated risk factors, sort of intermediate level, but when you layer this macro level pandemic event over people, it pushes them over the edge. So I think that's really interesting. And what I want to do, it's too early yet, but I want to follow up these individuals. So I want to see if this very localized, discrete event of pandemic loneliness can lead to different outcomes, say, compared to this consistently low loneliness group. So I would like to follow them up in the registers and see how they're coping, just like people are trying to do with people with long COVID as well, to see if this is just a fleeting expression of dissatisfaction or if it has deeper consequences for how people live. And finally, coming back to our themes, got a weak thumb, apparently. Let me see if it goes back. No, my button's not working. Oh, here we go. Okay, so a bit more about the healthy donor effect. So we know, as I said before, we have these blood donors, and we've looked at this a lot, and blood donors tend to be healthy, wealthy, white people, right? So we have this huge disparity in terms of what people might call the general population. So there are some methods we can try to address this generalizability issue for our findings. There are some statistical methods. For example, in Denmark, we have excellent background demographic data on every member of the population. So if you take in a factor like unemployment, we can look in our cohorts, we can look at the general population and do some statistical adjustment. Again, this has limitations, and it depends on places where you have this data-rich environment which have obvious biases. Then, coming back to the genetics, my field, we have some chronic problems in terms of vulnerability of people. So these studies generally are less effective for people from non-European ancestry backgrounds. So the genetics, it requires that this paper comes out somewhere where they've looked at this somewhere in the world, and these are overwhelmingly biased to people from white European ancestry. So as a precondition for a lot of these analyses, people from non-European ancestry are simply removed from the analysis because we can't estimate these genetic risk factors for them. And it's a double-edged sword. So it's created a culture. There's been efforts to increase participation in genetic association studies among people of African ancestry, which are particularly restricted. But there's still a culture of, due to publication pressure and needs of people, simply excluding these groups due to technical challenges. So I'll just leave it there as some sort of stimulation for questions or thoughts from other people. But yeah, and that's me. Thanks.
Thank you. so important insights. Please take note for your questions and remarks. And I would like to leave one for the common discussion, or for those of you who are in the field also of policy making among the listeners here. How can we really ensure in Europe that the inputs that come from academic research are used to inform relevant policies? And I'm giving one example. For example, the previous EU Anti-Racism Action Plan, the one that is finishing now in 2025, as many other policy instruments on equality, non-discrimination, are not based and do not take into consideration academic research, do not take into consideration data that does not come from Eurostat or the Fundamental Rights Agency. And this is a blind spot, it's a bias in itself. So that's what we are working towards, and really think collectively what can and must be done in order to mainstream this sort of input into policymaking for the purposes of prevention, and especially considering your research to the huge responsibility, and you're going to speak also about ethics, on not falling into the trap of genetic determinism and the abuse of certain concepts that might come from the scientific field. Now, this said, we continue with our last panelist, with Teresa Hendel. Again, I will leave you some space for you to introduce before your presentation the networks that you have founded and intercontinental research groups also, which you have co-founded. And Teresa is a political philosopher. She specialized in normative health ethics from the University of Augsburg, and currently she's a visiting researcher at the University of Warsaw Center for Bioethics and Biolaw. She investigates concerns of oppression, vulnerability, refusal, empowerment, justice, and solidarity, and the ethics and epistemology of health technologies and interventions. And she also, through her work, contributes to the discussion and the very highly controversial topic of reparations and epistemic reparations. So, Teresa, the floor is yours for you to share more light on transformative technologies and how to ensure equitable and just health outcomes with digital health. Thank you.
Thank you so much. Can you hear me well? Okay. Thank you so much, and thank you to the organizers for inviting us and having us and organizing this day, because it involves a lot of interdisciplinary conversations that I find really important and that we need to have. I will talk today about transformative technologies, and it's a huge topic, but I've worked on a research project that looked at digital health for over 6 years. So we were able to actually really look deeply into all different kind of aspects of digital health and concerns of equity. So I will try to condense it into a short presentation, and where I will not have the space to go into detail, I will give you leads where you will find where we wrote about this. And just to begin with, I am finishing currently an edited volume that is on intersectional ethics for a global society with digital health. And it's quite a massive book that involves perspectives from all over the world. We really went out and tried to get perspectives from people who are working from, for example, also indigenous communities in New Zealand, Aotearoa, and Australia. So I hope that this is work that will contribute to discussions about global health justice from the perspectives who have not been heard before and heard enough. And this book will be open access, hopefully next year, so it will be free for download all around the world, which is the point. And I hope that some of you will get to read it. There has been much hype about digital health and how digitization can fix major health inequalities that are persistent in our world. There has been much hope that they will, for example, provide access to health services to population groups who have not had the chance to get high-quality health services. And there was also a lot of hope that they would offer person-centered approaches and high-quality healthcare, and that they would really revolutionize health worldwide. Now, these hopes have not quite materialized. There is a very growing pool of evidence that shows that a variety of digital health technologies and machine learning systems and medical AI come very short of providing rigorous health information, and that equitable health services and outcomes are still a long way to go. Much research shows that many technologies used in medicine or health apps have not been trained on heterogeneous data and are thus not serving whole population groups, and subsequently are not suitable for use across the whole population or globally. And I think Maria really showed how that works, for example, with FemTech. In particular, many studies have shown that AI platforms are commonly trained with data skewed towards a partial segment of the population, usually white Western men, and as a consequence deliver poor, false, and potentially harmful results. For example, the study that you see on the slide looks at how AI systems working with medical imaging datasets fail to deliver correct diagnosis in women, owing to the overrepresentation of male data in publicly available X-ray images and datasets, and deep neural network architectures. And the authors of this study note that a consistent decrease in performance is observed when using male patients for training and female for testing. And of course, vice versa, but that vice versa is not usually done. We assume that male bodies are normative and research on them can be inferred to everyone else, and it doesn't work that way. It does harm. There is also growing pool of evidence of the persistent inequalities that further, and how they further magnify. They are further magnified by digitization and automation. So when we source data from unequal environments, we get data sets that reflect the inequalities in those environments and further then magnify them through algorithms. At times, this problem is already carried in clinical studies. For example, we have evidence that Black Americans with sickle cell anemia get overdiagnosed and needlessly treated for diabetes based on data from studies that exclude them. And automation, again, magnifies this problem. And at other times, the design and training of new technologies is when they're trained on skewed data, is then introduced with the discrimination in data sets that are newly created. And so this was, for example, the case of a Google dermatology app that has been found to be almost entirely calibrated to white skin, with only 2.7% of data samples of the second darkest skin type. So this is a tool that will likely wrongly diagnose or overdiagnose or misdiagnose people with darker skin tones. And I think what should concern us, and what should also concern the legal scholars here in the room, is that in spite of these glaring inequalities in the data set, this app was certified as Class 1 medical tool in the EU, which in this context really raises serious questions not only about the rigorousness of the quality of the design process of the technology, but also about the approval and certification processes for digital health and the criteria they actually involve, and whether discrimination and inequalities are part of it, and whether, for example, health benefit is thought about in intersectional ways. And at times, the distortion in the data begins at the clinic and continues through the healthcare referral process. So we know that research on the implications of SKU data sets in mammography screening shows that clinicians spend less time with negatively racialized and socioeconomically disadvantaged women. These groups of women then may not be referred to specialists, and their diagnostic data will thus not reach into the databases that are used to train machine learning systems. And the absence of the training data then likely will have a disproportionately detrimental impact on the same population groups, as conditions that might be population-specific or more prevalent in particular groups as well because of, for example, socioeconomic deprivation, will not be well documented and might be harder to detect, and this effect will likely be magnified again through processes such as algorithmic discrimination. And these issues point at intersectional inequalities and injustices where the several layers of structural disadvantage and discrimination intersect and generate specific and often magnified patterns of discrimination and unjust health outcomes. I want to just check in the room how many of you know this example, pulse oximeter. Have you? Okay, few, perfect, but some of you, and quite many of you, that's wonderful. Or I wish it never happened, but I'm glad you know about it. This is a case of a digital health tool that was used during the COVID-19 pandemic, right? And it measures oxygen saturation, and it attaches to your finger as a cloth bag. And basically, during the pandemic, where hospitals had to triage patients because they couldn't take all of them, it was used to measure blood oxygen saturation and infer the health state of the patient. And people who were considered relatively healthy were sent home for self-monitoring. And studies shown that basically this tool, again, is unable to correctly read blood saturation in patients with darker skin tones and around 3 times less likely to actually read their health properly. So this would have cost lives. And my final example is a study that has shown that X-ray imaging data sets basically, again, misread people's health data and basically deprived millions of Black patients of access to healthcare. And how this worked is quite remarkable because this points to a problem of also black box design when we do not know what exactly is happening with the algorithm, why is it doing what it's doing. An investigation shown that instead of interpreting individual patient health data, the algorithm was inferring the diagnosis based on health spending. And because we have inequalities in our environments, and we have inequalities in the referral process, people who already face structural disadvantage will have lower health spending. And that is a result, again, because they are not referred to specialists. Again, when you automate diagnosis based on this data without checking what might happen in the process, it can lead to the magnifying and exacerbation of those health inequalities. So we have the situation that there is a growing pool of evidence of unequal health results. And simultaneously, there is a striking lack of evidence that digital health would produce health and equitable outcomes. We also, at this point, still lack evidence that digital health produces health benefit. A lot of them actually have not produced hard evidence of the fact that they actually work, especially in the long run, and this is a major issue. So I think we also need to sometimes change the way we think about benefit, and we think about, rather than thinking about we need to provide more evidence that there is harm done, we actually need to ask providers to provide evidence that there's some benefit offered. And there is an argument that health technologies should offer health benefits. That's why they are also, for example, certified as medical devices. So this brings me to my question about, this is now going in a strange direction, right? The presentation. How do we design digital health and AI in ways that will positively transform human health? And I think we really need to start thinking about intersectional health justice and equitable health outcomes, and move beyond the kind of thinking that one mold can fit all, because it does not. And we have enough evidence that it fails. And we need to also, I think, really move beyond the thinking that if we just design technologies that will not make things worse, that's enough. Because within an unequal world, you still get inequalities incorporated in these technologies, and you are making them for an unequal world, so they will replicate them, right? So we need to actually start designing technologies in ways that intervene into those inequalities, that see them, that really fundamentally engage with them, and that they actually address them, they mitigate them. And we will have work forthcoming on this. And I think we also need to move beyond just thinking about bias, diversity, and inclusion, because these debates very often end in very individualistic sort of understandings of issues, where what we're really dealing with are structural problems, and structural problems require structural solutions. So I often see in a lot of literature, and sadly a lot of bioethics literature, preoccupation with privacy and autonomy, and the responsibilizing of people for their health outcomes, for example, with debates about how we need to more educate them so they know how to track on their app, where actually what we need is to create a system where providers will be made responsible for designing technologies that actually empirically offer health benefit, and they offer health benefit across the whole population that the technology is designed for. And that means intersectional health benefit across many different population groups that involve people who are vulnerable. And I think that this is where it really matters, how we regulate digital health and AI. And this is for other experts in the room to really talk about, because this is not my field in philosophy. But we really do need to think about the medical certification processes and whom they think about, right? And whether they make people more vulnerable. But there is also another issue that I think is arising, which is broader, that is often not thought about enough. And this is also whose epistemologies and approaches to health do the technologies reflect on, and who they might leave out. And at the beginning of the year, as part of work on this book, I went to Australia, which is where I also used to work in the past, and I was quite in touch with Indigenous experts who talk about major inequalities in health in countries that have colonial legacies. And Azur Hermes is one expert of genomics who will be contributing to our book. And she basically spoke about research practices where children, Indigenous children, were snatched on their way to school, and blood was drawn from them for checkups. And this isn't some ancient issue. This is 80s, 90s. So people who are affected would be my age. And so she was talking about what we do with the data that has come from these violations and whether this can be used in research and under what conditions. And she was speaking about agency of the people who have been affected and how also describing really empowering practices about how they build research ethics committees now and are really turning the practice around, taking agency and making stop to research of this kind. And from that also came, for many of these violations, came focus on indigenous data sovereignty. That there are a lot of populations who have been made vulnerable systematically by systems of oppression who actually do not want to share the data. They want to be, as you were talking about, part of genomics research because they want benefits from research. They need it because their health has been so violated and also neglected. But they have whole sovereign approaches to how that data can be handled and who can make decisions about it and who can have access to it, and they don't want it to be shared with institutions who have done systemic harm about them. And I think this is a really important line of work that also needs to be taken into account in debates about One Health, because it really challenges very old assumptions about how, for example, more sharing of data means more good, and this is something what we should aim for. So this will be a really incredible interview that we will be publishing in a book where she tells about how indigenous communities are turning this history of ongoing harm around in empowering ways that support their agency. And I think that there are also a lot of concerns about environmental issues surrounding digital health, because just powering digital health and AI takes so much energy that if we are going in a way that just puts so much focus on digitization, we're basically also going in a direction that undermines our environment, which harms our health, which is quite a vicious cycle. So what is the solution to that? How can we manage human health in ways that are actually environmentally sustainable? And that's it for me today. I think I want to end just on a thought that I think it's really important to have transdisciplinary conversations, because from our sort of corners of different disciplines, we see different things and different problems. And for example, in my talk, I mostly built also on a lot of scholarship that is outside of philosophy, because philosophy has not been good at thinking about justice. It has a history of white male philosophers who thought that they can think about justice from their sofa and they can imagine what injustice and justice look like, and they very often were not affected by injustice. So I think that we really need to read outside of our disciplines, but we also need to really deeply engage with empirical evidence and empirical research and material reality, and that's the way I think how we can make technologies that will actually implement some justice into the world that really needs it.
Thank you very much. Oops, this was very, like this distance? Okay. Thank you very much. Now, I'm rushing a little bit because we have 15 minutes for questions and answers. I think we have until 11:10, if I'm not mistaken. And it's going to be really nice to take your reflections and concerns. If you want to address them to any one of our panelists, please say so. Otherwise, whoever feels empowered enough and knowledgeable to answer, you will take the floor. There we go, our first question. Sorry, it's really difficult to see from here. We have one question after this. 1, 2, 3, 4. Okay, so let's start 1, 2, 3, and then the second round. 4, 5, 6, and we continue during the break. Okay? Should we pass the microphone? You will help? Thank you.
So thanks a lot. It was really a great panel. So I'm an engineer by training. I'm professor in Manchester in the UK. And so I come more from the technology point of view. But I've been reflecting and talking to people from your own disciplines as well in the past. And I have this question that I want to pose to you. So to what extent the technology is the cause of the inequality, or is it actually something that makes it more evident that that exists? And some of the examples regarding the availability of data or some of these sources of inequality to me seem like long-standing, right? So to what extent we could also see the technology as a mechanism to make it more evident and also to potentially come up with solutions. And just to give one example, to the example of the plethysmograph, it's not just one device. All of the plethysmography that is done on finger, which is pretty much everybody has been done with that problem. And I learned recently that there are people looking at plethysmographs that go through the ears. Apparently, the ear canal has the same pigmentation irrespective of race. So if you source it from there, the information, you have none of those problems. So, but again, that requires a new technological and some doctors that actually figure that out. Thank you.
Thank you for adding that. I think that also this raises what you're saying. I am super happy to hear that there is technology that can do it right. And to me, this really raises an issue of testing. If that technology was tested for this, if it's doing it right, we would have known it, right? And so it seems like we really need some procedures. And again, this is for the lawyers in the room, please take this further. Because a lot of the technologies that are designed are not actually required to be tested. And so, for example, we worked on the project in Germany. There was a policy at one point that you can introduce an app, for example, and then for a year you're using it, and then through that you get some data, and then you give it to the regulator, and they will see it if it's fine. And I find this really problematic, right? This should concern us, because that means that there are health technologies introduced into the market. People are invited to use them. They were even reimbursed by the government. So this is a governmental policy. And then in a year, you can see that it does harm, and it does harm to particular groups. And there is no procedure actually in Germany, because it doesn't collect data, and it doesn't collect data on that would allow us to trace who is harmed. You would never learn actually about the pulse oximeter, because Germany would not enable the collection of data on who it is harming. So we were happy that, happy is the wrong word, but that this was actually tested in the US and UK, because we would have never known. And so this is really a question of how do we improve legal systems that will actually implement non-discrimination in medicine, health, and digital health, and certification and testing of these devices.
Thank you very much. Irina Kireva, PAO International Legal Expert. So my question is more in the legal domain to Dr. Maria Zano. In your slide, you had a title, Sexual and Reproductive Rights. Please explain a bit further what is the scope of those rights, and since the issue was gender matters, why do you believe then there is a difference between men and women in that context from the legal perspective? Thank you.
Hi, my name is Beatriz Barros. I work for Cienzano, the Belgian Public Health Institute. I thought the topics were super insightful, and I really liked for you to focus on GDPR, but my work now is focused on the EHTS, and I find it very curious because I see a lot of correlations with the challenges that you are highlighting, because we are working on the guidelines to be based on the implementing acts of the EHTS, and we already see that there are a lot of discrimination in the way the regulation was designed, just because it assumes a level of digitalization across the health domain that is simply not there, and it assumes that we are all starting from the same starting point, which is also in practice not true. And I can already see, and I get in contact with a lot of data holders across Europe that report these challenges. The premise is very wonderful that we will have this data catalog with all the data available, but it is also very difficult to achieve because it will, in practice, just represent a subset of the high quality, very structured data that very specific data holders would be able to comply with. So my question was more related to, we see these challenges, we have this evidence, what's next in terms of the process of policy making? I'm curious to see what is your opinion on what can be done, what can we do for this evidence and this feedback from the real world to be more applied into the policy making, and also in terms of accountability. Should we have more accountability processes so that the policy making processes that are creating these regulations have a streamlined way to implement more evidence before it is under force? Thank you.
Perfect. Thank you. You have mine.
Okay, thank you so much. Can you hear me? Okay, thank you so much. That was a brilliant question, actually. What is the scope of sexual and reproductive rights? We do have some international instruments that tell us that. We can look at the CEDAW, that tells us that has provisions on sexual and reproductive rights. But again, these instruments, you can argue they're also kind of older, so things are progressing. I agree with you that we don't have anything explicitly written, but I have very clear ideas in mind of what data harms could arise from the infringement of digital kind of, but sexual and reproductive rights. Starting with, well, abortion issues and the right of choice for women. And if we have, and these are real examples, they're not hypothetical examples that I came up with, they're actually real examples we found in the media. So, for instance, there was an app, a femtech app, the fertility and ovulation app in the US that was funded by anti-abortion campaigners. Now, imagine women using this app. If we look at the GDPR, it has very specific kind of categories. Controllers, on the one hand, and then data subjects and processors. So where do funders stand? So where do these categories of developing an app and putting it out there come through? And then if we are thinking about, so I think all those are beyond what the law has and the GDPR has tried to think about or conceive. And then we have, and then imagine if that app is, for instance, used by law enforcement authorities to prosecute women that are seeking abortion and so on, so criminalize essentially what they decide to do. So, but I think there are international instruments to look at, in particular the CEDAW, and there are different rights, sexual and reproductive rights. In terms of the gender aspect, I wouldn't think that, and I would never argue, I don't know if this came wrong somehow, that rights and the law should be gendered. I think it should be equal across, and equally distributed across genders. What my problem is that technology is gendered. So femtech surveillance is gendered. I mean, we cannot ignore that it affects women predominantly. So that is my problem, that the law kind of ignores that additional layers of surveillance can be imposed on certain parts of the population. These could be women, whether you consider them vulnerable or not, or more vulnerable people. That is my issue, that with the technologies and the additional burden of surveillance, and then whether this is somehow reflected in the law. Absolutely, I agree, sexual and reproductive rights also for men. We do mention potential examples affecting men, but I actually have only one in one of our papers, and it's to show that, yes, there could be gendered issues also for men. That's why we do need some kind of recognition of sexual and reproductive rights, or the importance of those, also in the realm of data protection or digital health more broadly. The second question, comment, that was brilliant. Thank you so much. So let's have a chat also afterwards. In the break, I am actually, it's the next step. So the first was kind of focusing more on harms, that already we do have a very powerful law, the GDPR, and does not look at specific, ignores altogether a specific category of data risks or harms. But now the second part is of kind of looking at potential empowerment of the law. Can it empower women beyond harms? What if, how do we build a gender digital good? How do we build a technology, a femtech technology that serves women, that is for the benefit of that? And do we have the regulatory frameworks that support that? So that's what I'm now moving on in my research. And I will be looking at that as well. So I agree with you, I don't have a paper. We're still in the process, don't even have a draft yet. So we're still in the process of thinking about it. But I think there are issues to consider. Again, I wouldn't take my analysis from the harms, which I find that there is really a gap, a regulatory gap, to the benefits, but I think there are also issues there to address, and I'm happy to discuss with you further on that. But yeah, completely agree with you. Yeah, and it's the next step actually, and actually something that I did not address in my
during the break, because we're already overstepping our time, and it's really important to take the last three promised interventions that we had. And then if you two would like to contribute anything to the already asked questions, additional, or we continue with the next round? Yeah? Okay, so we had three more hands. 1, 2, and 3. Who will help me? Can you pass the microphone, please? Okay. Here, the lady on the third row. Then we take the second and the third question together.
Thank you for the brilliant panel. It was very interesting. I'm Virginie Pirard. I'm the vice chair of the Belgian Bioethics Committee. And I wonder, this is a question for Dr. Tsanou and Dr. Handel. I wonder if we shouldn't take the picture a bit bigger, in fact, because GDPR is a powerful regulation instrument, but the question is who will check that compliance is granted. And when you speak about femtech, you have told us that many times they do not recognize that they use health data. And of course, this is not right. They bypass the GDPR. As well, they do not use, or they do not practice impact assessment. Once again, the tool is there, is in the GDPR, but they don't use it. So from my perspective, I think that it's not the regulation tools, but the issue is more who will check the compliance. Mm-hmm. And there you have indeed an issue which recover many damage already done to women or other vulnerable groups. And my second point is to bring to the table that ethics committee do a lot, in fact, in protecting vulnerable population, be they women, illiterate population, stigmatized groups. This is the work of ethics committees, in fact. And in research, we do that all the time. So there is the law, there is the ethics standards, but you need a body or instance who does that, and that's ethics committee. Thank you.
Thank you very much. Let's take the last two. If you have a reflection, let's keep the reflections for outside. If there is a very specific question, we were supposed to be closing 2 minutes ago. And also the answers, if there is a very specific answer now, please go ahead. If it's a reflection, we take it outside during the break. Go ahead.
Thank you. My name is Ruoxin. I'm a PhD researcher at VOB, and I'm also part of the organizer of this event. I have a question for Maria for her presentation. So first I would to thank to Maria because it's very useful to learn from the empirical evidence about how femtech application have the insufficiencies about protecting women's health and also the implementation to the women's other health rights and also the reproductive rights. So my perspective is actually it's from the human rights framework because I found the topic of femtech is interesting because it's kind of intersection of different fundamental rights, for example, the right to privacy, right to data protection, and also reproductive rights, and also the prohibition of discrimination. And also, when I did my research, I found a very interesting case about the relationship between femtech and the right to freedom of speech. So which is a company based in Ireland providing information for women who want to do abortion outside the country. So I found it's quite interesting because it's always complicated with different human rights. So my question is, to what extent do you think we can be inspired from the existing fundamental rights framework in Europe or within the European Union to improve the regulatory framework for femtech? Yeah, because we all know the insufficiency of the human rights approach. For example, it reacts slowly than the technologies, and also we have the case law resources.
I'm very sorry, may I interrupt you? We take the question on the impact of the human rights framework, how it can be taken into consideration. I'm really sorry to be in the bad role to have to interrupt you. Just to take the last question because we have to stop.
Yeah, that's my question. Thank you.
Thank you.
Hi, Veronica Popa from Eurortis, patient advocacy organization. So my question is pretty short. How would you address introducing this matter into the GDPR, considering that we are using sex and gender interchangeably, but they are not? Gender is also a matter of identity. So we would have to use sex. How probable do you think that a European legislation would define the word sex in order to address this matter? Thanks.
Okay, brilliant questions, all of them, but Mila is really putting some pressure on me. You're absolutely right. I think it's because the focus of my talk was really to kind of highlight that the law is problematic as well, besides the technological compliance. In my view, it is problematic when thinking about vulnerable populations, and even if you don't define women as vulnerable, but whole populations kind of being ignored or blind spots. That's what I wanted to highlight, but absolutely you're right, it is a very powerful law, and we do see a lack of compliance, and that's what we found. Again, I have to say that our report is a little bit more nuanced. We say the bigger picture is partial compliance, and that is problematic for me, because we find that they do mention something and they do comply partially with it, but partial compliance is non-compliance. So again, I wouldn't say, some are very, very bad practices, some are very good practices, but what we see is, even in very strong apps and very popular ones, that have been fined by regulators in the US and everywhere, still partial compliance. But again, for me, that is problematic compliance, non-compliance. The second, Roisin, great points. One line, definitely agree, fundamental rights, really important for this framework as well, for its context. Again, I wouldn't think that we need particular regulation for femtech, not at all. I think I wanted to use it as a case study to highlight gendered aspects and blind spots in the context of data protection. And I think fundamental rights are very important. I do know the concerns about fundamental rights, but I think they are very important to consider because they give us benchmarks and they're very important.
Let's pass to Liam and then to you to close, and we take the conversation outside. Yeah. Yeah, because there is the next panel.
Yeah, I just have a little reflection. So I don't know much about health tech so much, but a sort of counterintuitive example of this intersection of vulnerability and scalability is with policy. So, for example, in Denmark, in order to change policy when people are administered blood during a very serious operation, it has to be based on a randomized control trial. These are very expensive and they have clear recruitment biases. So in a sort of optimistic note, there are people who are working on this a lot, and they propose new statistical methods referred to as emulated target trials, where we can use big data to affordably create multiple randomized control trials which can take a broader spread. So I just wanted to say that, yeah, in terms of regulation, you can have the opposite effect where proof of effectability can lead to skewed outcomes for vulnerable people and their applicability ultimately in this case.
I just want to also add to the question about the ethics committees and how, yes, they're important and they're doing important work, but I would also want us to think carefully about whose approaches to health and ethics they have historically centered, and which kind of ethical issues weren't thought of. And this is actually something that where I think a lot based on the conversations I was very honored to have with indigenous people around the world, and how their concerns and their approaches to health have not been centered as part of these ethics committees. And I think what comes out of this as well is a really major critique on vulnerability, and how we need to focus on the structures that makes people vulnerable, rather than, for example, essentializing some people as vulnerable people, because then they are not having agency within these debates as people who drive the ways that we think about health and ethics. And I would really want to emphasize this and have us think about it more.
Thank you very much. Let's continue with this conversation and contacts can be received through the organizers of our panelists. Thank you very much.